Hello, and welcome to another episode of Hybrid Healing Hour. Today, we have a special guest with us, Dr. Julia Ladna. And the reason I'm doing this introduction is because I've known Julia quite a long time. I met Julia, I think, in her first or second month of medical school. And I can tell you, I knew then, that month, that she was going to be a cardiologist. So, Julia, tell us, why did you decide to become a cardiologist?
Well, hello, everybody. Thank you for that wonderful introduction. I think my path to cardiology was kind of a circuitous path in a way. After I graduated my undergrad at Boston University, I serendipitously had my first job at Brigham Women's and Hospital at TIMI Study Group, which is a major research group in cardiology, and I got to work with the big names like Dr. Braunwald. At the time, I didn't know how lucky I was to be part of such an amazing group of people, and it really kind of sparked my interest. Then when I went on to medical school at Nova Southeastern and did my residency, I noticed basically that I was gravitating towards patients who had cardiac disease, and I think a lot of my background helped me with that.
And so today we're going to be talking about valvular heart disease.
Yes.
All right. So everybody talks about arteriosclerotic coronary artery disease, and that seems to be the focus. But valvular heart disease is important too, right? So let's discuss
Very
why.
much so. So, just to define, valvular heart disease is, it's a dysfunction, either structural or functional dysfunction of a valve. That kind of either results in one of two things. Either it's regurgitant, which means it's effectively not closing, or it's stenotic, which means that it's not opening. There are four valves in the body. You have your mitral valve and the aortic valve on the left side of the body, on the left side of the heart, and your tricuspid and pulmonic on the right side. To give you some statistics, valvular heart disease affects approximately 20 million people in the United States. There are some congenital forms of valvular heart disease, and that population is very small. But most valvular heart disease occurs in the elderly population over the age of 65. About 3 to 6% over the age of 65 get valvular heart disease.
And once upon a time, it was rheumatic heart disease, right? That was the number one cause.
That's true. And to an extent, mitral stenosis is still prevalent. Rheumatic mitral stenosis is common, though the incidence is going down. Now, I think what we're dealing with more is the calcific mitral stenosis as well as aortic stenosis.
Why is that? What's the most prevalent one?
Right. So aortic stenosis is the most prevalent valvular heart disease in the developed world. Okay. And mostly, I think, because of our Western diet and our lifestyle these days. Rheumatic used to be the most common because rheumatic is a complication of essentially strep throat. So a lot of, third world countries, underdeveloped countries do not recognize these things. They don't screen their patients. So unfortunately, these patients tend to have complications decades later.
Wow. And so when we talk about these valvular heart disease, I guess I'd like to dive into, let's start with one, and we can talk about each one individually.
Sure.
But with aortic stenosis, who is the population that's at risk for this? And how are they diagnosed? Do they have signs and symptoms? Do people know they even have this going on?
Great question. So, like I said, aortic stenosis is the most prevalent valvular heart disease. The risk factors of it include high blood pressure. So your traditional risk factors for heart disease, a coronary disease, high blood pressure, high cholesterol, diabetes, kidney disease, just abnormal metabolism of calcification, any inflammatory diseases, systemic inflammation, all of that is contributing to the buildup of calcium on the valve, okay? With kidney disease, those patients tend to have calcification at a much earlier age than the general population. Things like smoking, obesity, all of those are high inflammatory states that, contribute to calcium buildup. Not just on the aortic valve, also on the mitral valve as well.
And a lot of times our first indication that someone may have valvular heart disease is a murmur, right?
Exactly.
But not all murmurs are bad, and people come in and say, I have a murmur, and they worry about it. So do you want to explain what a murmur is?
Sure. So a murmur essentially is, it signals an abnormal flow through an orifice, and the orifice being the valve. Okay. So we have different types of murmurs to help us kind of identify which valve is at risk. Like you mentioned, kind of the murmur that you hear with your stethoscope is the first sign that something may be going on before the patient develops symptoms. Because generally we know that many of these heart lesions take decades to build, and patients typically don't have a lot of symptoms until the lesion or the valve stenosis or regurgitation is severe. So that's why it's so important to have a detailed history and physical exam. And why we spend so much time talking to our patients about their symptoms to help us clue in on some of these things. And then, obviously we kind of follow it up with testing afterwards. The most common, for aortic stenosis, the most common cause is exertional dyspnea, which is shortness of breath with exertion, syncope, which is passing out. Okay, and angina, which is chest pain, usually with exertion. So those are kind of the most common causes.
Symptoms. Okay.
Of aortic stenosis, and that's when we start to, by that point, usually they are severe. But as a primary care physician, hopefully they listen. You're listening to your patients every single time. You would hear a systolic murmur. That would kind of clue you in that something is going on, and with the exam, the where the murmur peaks is the most important part. It's not really how harsh it is, but where it peaks. So usually the severity is determined by how late it is in the cycle. So usually if sometimes we have either, you have your S1, the first heart sound, you have the murmur. If it's late peaking, that should signal severity. And when aortic stenosis becomes very severe, the S2, the second heart sound, becomes completely absent. You also have delayed carotid upstroke, which is your pulsus parvus and tardus. Some other signs are there's the head. There's different kind of maneuvers. There's like the head bobbing maneuvers and
what's a JVP? Is that? Can you look at that?
Sometimes. So that's more a sign of heart failure and fluid. Exactly.
In our practice, I feel like, if we listen to heart and carotid, and
Yes.
if I hear anything, I'm like, let's go for imaging and see cardiology.
Exactly. So it's a murmur that usually radiates to the carotid, so you should always be listening at the carotids.
And when we examine our patients, a lot of patients comment on why we move the stethoscope around, right?
Exactly.
Because you can actually listen to each separate valve.
Right. Different posts, right? So aortic is usually right-sided murmur. And again, you always listen to the carotids because you'll hear the radiation to the carotids.
So what do you do for somebody, let's say they have aortic stenosis?
Right. So
What's the recommendation?
I think all of our tests usually start with a 12-lead EKG, okay? Echocardiogram, which is kind of the baseline test for all of us because it helps us understand the hemodynamics of the valve, kind of the remodeling of the heart to the heart issue, essentially, to the valve disease.
And an echocardiogram is essentially an ultrasound of the heart.
Exactly.
Right. So it's non-invasive, no problems,
Exactly.
no pain.
And usually we get also a chest x-ray to understand kind of, calcification, if there's pulmonary congestion. So those are kind of the three that we start out with. In terms of aortic stenosis, as I said, most of the patients are really asymptomatic until it becomes severe, though once you have severe aortic stenosis, about 75% of patients will develop symptoms or will pass in the next 5 years. Okay. And once you have symptoms, the life expectancy is about 1 to 2 years.
That's if it's untreated?
Well,
or if it's
untreated,
caught
but
too
medical
late.
therapy is usually not effective when it's already severe. So that's when you should be thinking about intervention, whether it's aortic valve replacement or the minimally invasive valves like the TAVRs, and which we can talk about a little bit. But the things that I wanted to mention is, with aortic stenosis, because the aortic valve connects the left ventricle to the aorta. And what happens is over time, because the valve is stenotic, meaning it's not opening, your ventricle, which is essentially the pump of the heart, will start to remodel. And first what happens is the muscle thickens because it's actually working against a very tight lesion. So it's trying to open up that valve, so it has to become thicker. And then you'll have inability to relax, which we called diastolic dysfunction. And then eventually it leads to systolic dysfunction, meaning the pump starts to fail, and then we have pulmonary vascular congestion. So those are the changes that we see, which most of the time is where we have these symptoms.
But that would be the end stage, like that's more when it's severe.
Exactly.
Right? When you get the congestion and everything.
Exactly.
Right. And so for a provider, like for our other providers out there listening, I mean, even patients who we always want to be their own advocate, at what point should we send for the echocardiogram, to get a baseline?
Right. So I always say if the patient has a murmur, you should always check it out with an echo at least once to understand. Some murmurs, like Brian mentioned, are just benign murmurs. Sometimes it's aortic sclerosis, meaning that the valve is a little bit calcified, but the gradients itself are not high enough to cause any hemodynamic issues. So, we grade our the way the aortic stenosis is graded is basically mild, moderate, and severe. And that's really the parameters we look at is the velocity, okay, of the flow that's going through it, the mean gradient, and the valve area. And there's really fancy equations to do that, which I won't bore you with. But really, it kind of helps us categorize where the patient is in the beginning and also understand kind of their symptoms with that. I always try to take the symptoms into account. But I like to screen early to understand what I need to be doing for my patients, or if I just need to be completely looking at something else. Maybe it's not valvular heart disease. Maybe their symptoms are because of coronary disease or pulmonary disease, whatever it may be. So like I said, echo first, that kind of helps you understand if they're in the mild, moderate, or severe category. And it also, if they are in that moderate to severe category and they're telling you they're not symptomatic, this is where I tend to do more provocative testing, because as patients progress in their valvular disease, we don't realize this, but we limit our symptoms. They don't feel so good, or they get short of breath, so they tend to walk long distances. And when you ask them, "Oh, are you short of breath with walking?" they say no. But the reality is they're not walking as much as they used to. Not everybody's going to be upfront with that.
And I feel, aortic stenosis does tend to happen more with age, correct?
Yes.
And so I feel like people kind of they're assuming this is an aging thing, right?
Absolutely.
And I like that we're talking about this, because I really don't like to use that as a I've worked with other providers and practices elsewhere where I've literally heard the doctor say, "Oh, well, you're not getting any younger," and I'm like, we should always investigate a little more. Let's talk about quality of life and get you back to where you used to, be able to walk from your car to your house and be fine and go for a walk, actually, but now you're not.
Right. So it's important to know number one, their symptoms. Also, if they are in that mild category, this is where I go back to the guidelines, and there's also surveillance. So if you're in the mild category, generally speaking, you should be repeating that echo in 3 to 5 years, or if there's a change in symptoms. If you're in that moderate category, it's usually about 1 to 2 years. Once you're in that severe category, you should be really repeating the echo every 6 to 12 months, or if they have a really significant clinical status change, because we all know that we build calcium in a different rate. Every person is very, very different. And for those people who are, in the severe range, but they're telling you they're asymptomatic, really, it's safe to do an exercise stress test for these patients. It should be done with a cardiologist, but you should be stressing these patients. It's a class 2A indication in the guidelines. And really what it helps you determine is risk of sudden cardiac death. If they can exercise well, they can give you a good exercise stress test at average functional capacity without any changes in their blood pressure, without any arrhythmias, without changes in their symptoms. Then that tells you that their risk for sudden cardiac death is essentially zero. If you stress that patient and they're really not able, number one, they develop symptoms, that's considered a positive test. If they drop their blood pressure, that's considered a positive test. If they have any ventricular ectopy, that's considered a positive test. So those are the patients that you should be referring to your, obviously hopefully you're a cardiologist at that time, but a surgeon to, get them a new valve.
So let's talk about treatment. And you mentioned earlier there's surgical and there's the minimally invasive. Who's a candidate for which?
So I think first things first, with aortic stenosis, as I mentioned before, it's really important to treat all the other risk factors. So things that will build calcium. So it's important that most patients will be on some sort of statin therapy, just because of anti-inflammatory properties as well as atherosclerotic reasons. If they have hypertension, you should be treating their hypertension. Usually ACE inhibitors, ARBs are really great for that patient population. It's important to also understand that when that echo was obtained, the patient needs to be normotensive because the blood pressure will change the valve hemodynamics. Very often I see patients getting these echoes, their blood pressure is 160, over 90. That will change the gradients. That will change the valve area. So the blood pressure needs to be at least 140 or below. I mean, they can't be hypotensive, but their systolics need to be 140.
And I'm wondering how many of our patients are getting accurate echoes now hearing that.
I know.
Right.
I was just thinking that too. I was like, that's new.
And just to be clear about something else, calcium is not the problem, right? Calcium is a marker of the problem, whereas people think that, because I have a calcified something, I need to decrease my calcium intake.
Right. It's not how much, and that's actually, I had a question in clinic the other day. Really, it's calcium buildup on the valve. So it's not like you shouldn't be taking calcium itself, but it's, it's a marker of inflammation and essentially calcium processing in your body. And sometimes it's, there's an issue with congenital. We have people who are born with a bicuspid aortic valve. And what that means is, it's a small patient population, but what that means is the aortic valve has basically 3 leaflets. Some people are born with 2 of the leaflets fused together. So it essentially creates this fish mouth appearance, and the valve is really not opening as it should. And those patients tend to develop aortic stenosis at a younger age. I like to kind of group my aortic stenosis by age. So usually if I see a patient that's less than 30 and they have aortic stenosis, most likely they have a unicuspid or bicuspid, usually it's bicuspid aortic valve. Your patients in the 40 to 60 age range, sometimes it could be calcified bicuspid valve, okay? Or it could just be rheumatic. But like we said, rheumatic is less common these days because we are better at treating strep. And if you're above the age of 70, it's usually degenerative, which is the most common cause of aortic stenosis. So that's another way to kind of differentiate and keep something in mind. And specifically, I wanted to just mention with bicuspid aortic valve, although it's a small percentage of the population, these patients tend to have an associated aortopathy. Okay, an aortopathy is an abnormal aorta because the aortic valve connects the left ventricle to the aorta. So meaning the valve is abnormal, it's bicuspid, but also you have to look at the aorta itself. Okay, you look at the root, the ascending aorta, and down. So let's I'm going to back up.
Yeah. So as we talked about the left ventricle,
right,
is like the main pump of the heart, as you said. And the aorta is like the largest artery in the body. It
supplies the blood to every other organ in the body.
Perfect.
Okay.
Yep.
So With the bicuspid valve, we also have to look at that aorta and to understand if there's any dilation of that, meaning it's enlarged for any reason, because we know that there's an association with the bicuspid valve and this abnormal kind of wall in the aorta. And those are the patients, at least 20 to 40% of those patients that with bicuspid valve will have an associated aortopathy, okay, which is why we need to be screening these patients usually with a CT or an MRI. Okay, of the whole aorta, because these are the patients that are predisposed to dissection. And with bicuspid, if you have a patient with a bicuspid aortic valve, it's really important to screen their first-degree relatives with an echocardiogram because it is familial, it's genetic.
Interesting.
Yeah.
Now, we talked about, blood pressure being a risk factor,
Right.
and calcium deposits also associated with chronic kidney disease. I'm assuming end stage, like later stages of kidney disease.
Well, I think what we know is CKD, unfortunately, it kind of causes more inflammation in the body, and that inflammation will wreak havoc on the valves. Same things with things like diabetes. Usually we have these patients who are diabetics who eventually will develop kidney disease, who eventually develop some sort of valvular heart disease, because it's almost like a cycle.
And then what about tachycardia, like racing heart rate? Does that affect the pump and pressure, of the ventricle and the aorta and the valve?
So tachycardia will affect it, because mostly it doesn't allow the ventricle to fill.
Mm-hmm.
So that's why the cardiac output, the blood will not be able to go into the aorta and basically perfuse all the organs. So usually when patients have aortic stenosis, the more tachycardic they are, the kind of worse off they become. But it is a compensatory mechanism, but it just doesn't allow the ventricle to fill enough, to relax enough to get the blood to then eject it to the rest of the body. So they tend to do worse, and that's what we try to avoid.
So typically when they replace the aortic valve, what are they replacing it with?
So it really depends. I think what I want to talk about initially is kind of the indications for replacement. And usually, you operate if you have any symptoms at all and you have severe aortic stenosis. So aortic stenosis, severe AS and symptoms, operation. You should also be operating on somebody if the ejection fraction, which is a marker of the pump, is below 50%, and you can do it without any symptoms. So that's also an indication for surgery. Do
you want to tell people what a normal ejection fraction should be?
So it varies between males and females. Generally, it's about 55 and 55, 65 is normal. I'll give a broad range.
I think people always get worried because they assume it's 100% and they see 50.
That's
they're
true.
like,
Yeah.
and I'm
That's
like,
true.
oh no, this is good. 55% is normal, and they're like, oh really? I'm like,
Yeah.
yes, you got A+.
So really 50% is low normal. So around that time, you should be thinking we should replace the valve. And then to answer your question, when you're replacing the valve, we have a surgical aortic valve replacement, and we have what we call TAVR, which is a transcatheter option. They really have similar procedural and long-term survival rates. TAVR, and that's a minimally invasive valve that we usually do through the groin. It doesn't require an open heart surgery. And the SAVR, usually in the hospital for several days. You have open heart surgery. They have to break the ribs. It's a big undertaking. Typically, we reserve TAVR for somebody over the age of 80, and if they have life expectancy less than 10 years, okay, or they're higher prohibitive risk to open heart surgery. And some of that is because they have a calcified aorta, so they can't clamp it. Sometimes they have kidney disease, they have liver disease, they have significant lung disease, so they just will not be able to tolerate such a surgery. The younger patients, so if you're less than 50 years old, you definitely get a surgical valve. And then it begs the question, do you get a mechanical valve or a bioprosthetic valve? Generally speaking, the patients who are in less than 50 get a mechanical valve. They're just more durable. But we are committing those patients to long-term anticoagulation with warfarin, okay? So So that's something that needs to be discussed. Bioprosthetic valves don't need that anticoagulation. So usually if you're between the age of 65 to, let's say, 75, 80, that's when we're considering a bioprosthetic valve. But all of that, and this is what I love about cardiology, we always do what we call the heart team discussion. And that's a discussion between the cardiologist, interventional cardiologist, and a surgeon. And we basically have a shared decision-making to understand what the patient wants, what are some of the indications or contraindications in the patient's wishes, and what would be, best served for that patient. So that's, I think, is really important. It really is the way I think medicine is practiced these days. Now everything is a big discussion, just because I think ultimately the patient, it comes down to the patient, and we never know how they may behave and some of the complications that may happen, and we kind of want to do right by them.
Yeah. Okay, so we talked about aortic valves. What's the second most common?
So really, it's mitral regurgitation. I think with mitral regurgitation, so the mitral valve is a valve that connects the left atrium to the left ventricle, okay? And essentially, dysfunction may arise because of any issue of the valve itself, the annulus, or the leaflets and the apparatus that kind of attaches to the ventricle. And they can, I like to differentiate these between acute, meaning sudden onset, and chronic, okay? And causes of acute mitral regurgitation are things like infective endocarditis, so infection of the valve. It could be ischemia because, if you have a blocked heart artery, it's not supplying blood to a part of the heart and the muscle essentially dies. And that area becomes kind of fibrosed, and you can have rupture of one of the papillary muscles or the cords, which will basically fling back into the left atria. And sometimes, although that's more rare, is like blunt force or trauma of any sort. So usually these patients present with significant shortness of breath. They have pulmonary congestion because all the blood is basically flowing into the left atrium and then backing up into the lungs, okay? And most of the time, these patients, actually, the murmur is really soft or even absent, okay? Because you have that quick equalization of pressures between both chambers of the heart. Usually the left ventricle is not enlarged, it's not dilated. And a lot of times, actually, these patients are really challenging to image. So, instead of getting a traditional transthoracic echocardiogram, meaning the ultrasound that's done through the skin, we do a transesophageal. And that also helps us understand the mechanism and kind of planning. Because most of the times, the treatment for these patients are vasodilators and surgery. Sometimes we do things called balloon pump to kind of help bridge the patient to the surgery. But generally speaking, acute mitral regurgitation always requires surgery. And I think the timing of that, again, it's mostly a heart team discussion, but usually we try to take them sooner than later because we can't really temporize them with much. We try to optimize them with medications and these balloon pumps, but it's a very short bridge. And then we have what's called chronic mitral regurgitation, which can also be classified as primary or secondary. And chronic, primary means that the issue is with the annulus itself, okay? And the most common cause of primary chronic mitral regurgitation is mitral valve prolapse, okay?
Which is not uncommon. A lot of people come in with that diagnosis.
So younger patients tend to present with this. It's usually myxomatous degeneration. Older population usually has fibroelastic deficiency that causes all these things.
I feel like the number one symptom that I see is palpitations with this one. Would you say that's
exactly? And I think that's part of the disease process, because what we know is when the valve is leaky, you have a lot of blood backing up into the left atria. And left atrium is a really fairly small chamber that doesn't accommodate a lot of blood. So when you have extra blood, the chamber has to dilate and enlarge. And essentially, the patients typically develop atrial fibrillation as a result of that, which often presents with the symptoms of palpitations, shortness of breath, congestion. Some of these patients have, they spit out blood. They're called hemoptysis. That's really extreme cases. Some of them have embolic events because they have undiagnosed atrial fibrillation that then embolizes to the brain. So
which is a blood clot.
Is exactly a blood clot.
And so with this, I feel like it's the young females that have a lot of this. So how often do you recommend screening them? If it is seen on a transthoracic echocardiogram, that, just a regular ultrasound through their chest, does that mean it may not be as accurate for this type of patient?
I can tell you that back in the day, we used to overdiagnose mitral valve prolapse. I think now the imaging and just the way we get, read echo and the way the images are obtained, it's not as often called on the echocardiogram anymore. So typically, I do follow these patients and just monitor the degree of their regurgitation. Like we talked about before, if it's mild, then echo 3 to 5 years, unless there's a significant change in symptoms. And, moderate's usually 1 to 2 years echo, and then severe is usually every 6 months. But as I said before, I really try to listen to their symptoms and how it affects their life. And that kind of helps me understand and plan for kind of what to do next.
And I have a question about the acute. So I guess with it being acute, it's actually a physiological damage still. There's no reversing it by treating the infection. Like say it was endocarditis.
Right. So you can treat the infection. But at that point, if the valve is already destroyed by the infection, there's no reversing that. So you treat the infection in the blood. Most of the time, it will not reverse the degree of mitral regurgitation or aortic regurgitation if it's already at that stage. That's a great question. So usually, this is where we treat it, and then we talk about planning for intervention on the valve, whether it's surgery or percutaneous treatments.
And is there a TAVR-like procedure for the mitral valve?
Sort of. So there is, this kind of leads me into kind of chronic mitral regurgitation because, when we treat patients, we want to treat them with diuretics to help them with shortness of breath, antihypertensives. If they have heart failure, we treat the heart failure and do the kind of the medications for heart failure, the guideline-directed medical therapy. You really want to operate if the EF is less than or equal to 60, or the ventricle itself is dilated to more than 40 millimeters. So that's indication for operation. And what we know is that the EF matters. So the people who have a lower ejection fraction, they do worse. So we just want to intervene on these as soon as we can. And ideally, if we can't do that for any reason, if the patient has a lot of comorbidities and they are not a candidate for valve replacement surgery, there are kind of percutaneous ways that we can optimize them. And there's been multiple trials right now on what's called transcatheter edge-to-edge repair. And that's the short term for that is MitraClip. And literally what it does is a percutaneous way. It's a transeptal puncture. It's a clip that we put together to basically bring the leaflets together and close the valve. We'll call it, it's almost like an Alfieri stitch. So that helps the degree of mitral regurgitation. Typically, though, these, the indication for the MitraClip is they need to be, right now it's been approved for chronic MR. That's secondary, but really we need to make sure that they're on most aggressive guideline-directed medical therapy. And if they're refractory to that and still have symptoms, then it's a 2A indication to get them to the MitraClip. And I've seen patients do remarkably well. Usually they are very sick, but ultimately I think that's another way to get them optimized.
So I just have a couple, I guess, general questions with these. How long do valve replacements last?
So I think it depends on the valve, whether it's mechanical or bioprosthetic. Usually anywhere between, 10, 15 years, sometimes 20. It really depends again on the patient. I think every year what we try to do is delay as much as possible for patients to get a valve done, mostly because every year there's better technology that comes out. So if a patient doesn't need it, we don't want to preemptively place one. But I think a lot of, valves can fail as well. And I think that's something that we need to remember as well. If people have, for example, indwelling catheters, I'm always very, very cautious because that's a way that they can introduce infection into the blood, and that can travel to the prosthetic material and infect the material because we know bacteria likes to stick to these organisms that are not innate to our body. So I think we need to be cautious with that as well, and really take in all the risk factors before we are putting in material that will ultimately stay in the body for a long time. And again, I think that's why age and risk, all these risk factors play such an important age for us to decide in the first place what we're putting in, whether it's a mechanical valve, whether it's a bioprosthetic valve, whether it's a TAVR valve. We can do things like a valve and valve too right now. So I think that's something that's pretty incredible. So usually when somebody has an open heart surgery already, they had their ribs broken, they have scarring in the chest. Redoing their sternotomy is really difficult. So those are the patients that if the valve fails, their bioprosthetic valve fails, we can put in a transcatheter valve in those patients.
Wow.
Which is incredible.
So while we're talking about valve replacements, what about antibiotic prophylaxis for people? What's the newest recommendations on who should get antibiotics before dental procedures or orthopedic procedures?
So if you've had infective endocarditis, you definitely should be prophylaxed. If you have any foreign body material, so mitral valve repair, whether it's a ring, mitral valve replacement, you have a bioprosthetic or mechanical valve, you need to be on antibiotic prophylaxis. If you have any of those clips or TAVRs, you definitely need to be on prophylaxis. If you have pacemaker leads, those are all indications for prophylaxis. And I think if we go to ACCHA, there's kind of a longer list. Dental, definitely procedures, things like colonoscopies, endoscopies are less concerning. Things like bronchoscopies, I don't think you also need to do it unless you're doing biopsies. But those are patients definitely need prophylaxis, as well as some unrepaired cyanotic heart disease, which we won't talk about today.
So, our practice is big on holistic, and I would love to know if there's any lifestyle modifications or integrative medicine approaches to valvular treating or preventing valvular disease.
So I think the same things that you and I both talk to our patients about, it really is, I think, basic. It's really important to have a good lifestyle. Make sure you're at a normal range for your weight. You're eating right, you're exercising. All of those things are very, very important to valvular heart disease. Making sure you're, keeping your cholesterol in check, your blood pressure, is in good range. If, your any kidney issues, kidney dysfunction, that you're taking care of that. Definitely diabetes, it's high inflammatory state. So these are all, I think, very basic things to help us kind of prevent the progression very early on and kind of delay the onset of these things, most importantly.
Wonderful. Is there any medications out there that could be causal that you know of?
Yes. Any IV drug use can introduce bacteria into the bloodstream, which can cause, destruction of the valve. So any, and like we mentioned before, any indwelling catheters, this is doesn't necessarily mean IV drug use, but any patients who have indwelling catheters, they have to be careful as well, because that's a kind of a nidus for bacteria to enter the bloodstream and, start growing on the valve. So those are patients that I'm really, really careful about, and kind of are really particular when I'm talking to them to see if there's any symptoms or if they have any issues as well.
So we talked about two of the valves. Is there anything briefly you want to say about the other two valves? Anything that people should know?
Sure. So I can briefly talk about, the tricuspid valve. I think regurgitation is more common than stenosis. Regurgitation, again, we group it into primary and secondary. Actually, secondary is the most common cause, and secondary meaning the leaflets themselves are normal, and the tricuspid regurgitation is from other cause. We know that left heart failure causes right heart failure. So things like, dilated cardiomyopathy, pulmonary hypertension, AFib, some of these things can be contributing to tricuspid regurgitation. So ultimately, we need to kind of focus on that first to improve the tricuspid regurgitation. Primary valvular TR, or tricuspid regurg, is less common. It's where the leaflet themselves are abnormal, and it's usually because of, if there's a pacemaker lead that can injure or perforate the valve themselves, endocarditis, infection of that valve. We know things like carcinoid, which are neuroendocrine tumors. There's congenital causes, rheumatic causes for destruction of the valve. And what you typically see with tricuspid regurgitation is symptoms of right heart failure, which is really your swelling in the legs, swelling in the belly. You have elevated JVP, which is elevated neck veins. And you have that classic holosystolic murmur that's heard best at the left lower sternal border. And what we know is, the tricuspid valve is not as well studied as your left-sided valves, but we know that the worse the TR, the worse the outcomes. And if it doesn't matter if the EF is good or bad. So really, TR is bad regardless of the mechanism. Diuretics are really the forefront of treatment of tricuspid regurgitation. But besides that, we don't really have much treatment. And even the guidelines in terms of intervening on the tricuspid valve aren't really that great. We know that if you're in the heart for any reason for like left-sided disease, there's indication to intervene on the right side. But we don't have a lot of data right now to support any kind of other reason to intervene. And I think a lot of more studies need to be done. And usually for tricuspid stenosis, which is tightening of that valve, most of the time, like I said, rheumatic and carcinoid, it's very, very rare. It's unlikely to be seen. You're really treating the neuroendocrine tumor and they're replacing the valve. There really is not much medicines out there. You're handling the volume and the congestion with just diuretic therapy, but really medications-wise, there's not much. You just have to, treat the neuroendocrine problem, so tumor debulking and everything else, to help you with the valve.
And the one we never hear much about, the pulmonic valve.
I'm not even going to mention it. I'm going to mention it most of the time because it's usually congenital. Mm-hmm. And a lot of times these things are repaired. So these are kind of handled by cardiologists. I would just refer them right away, or congenital cardiologists and specialists.
Wow. Well, just this has been very informative again. Thank you so much for coming on. But I was wondering if you have like a quick patient story or anything that has like changed your outlook on valvular heart disease, or how you would treat it, or anything.
Well, I would
different.
just say, like I said, every patient is very, very different. So it's really important to listen to people's symptoms. I think there's a lot of tests being out there that are done right now, and patients are in and out of the hospital for various reasons. Some people even get an echo, and they are kind of sent out of the hospital. And they come to me and with these echo findings, and I know that their primary problem why they were in the hospital was addressed, but here I am with a patient who has really significant symptoms and has severe, whether it's aortic stenosis or mitral regurgitation. So I recently saw somebody who was actually in the hospital, was in ICU for, septic shock, and he was on pressors, and he was very, very sick. And he comes to me, and he was a very young guy, actually, I think in his 50s or 60s. And sure enough, he has the echo report that shows that he has severe aortic stenosis. His EF was already decreased. And, he had severe, life-limiting symptoms. He could not work. He could not walk. So I just ended up sending him straight to the hospital. I said, you just need to be seen by a surgeon now, and you need your valve replaced. There's no way he could even function to even go home. And I actually saw him in clinic very recently, and he's doing remarkably better. So like I said, the surgery is really the life-saving portion. All the other medications are for symptom management, but ultimately when a patient becomes in that severe range, we should be intervening. And sometimes we're intervening already too late when there's already changes and remodeling to the heart in a negative way. And sometimes we can have recovery of function, but in some cases we can't, which is why I think surveillance, screening, and preventative things are so important. And it's so important to talk to your patients to understand what their symptoms are. And if you don't believe them, or if their symptoms are not correlating with the tests that you're getting, get a different test. And try to elicit those symptoms to understand really where they are in that risk bucket, whether they're in that very low risk, intermediate risk, or high risk. Because what we know is the worse, once it's severe and you have symptoms, we know that outcomes are bad. And once we have a drop in LV function, the outcomes tend to be even worse. Yeah.
This was excellent. Thank you so much for coming on our podcast. And
thank you.
And I think that even we got a lot of information out of this. So,
and we hope you all did too.
Yes, we did. This is amazing. Thank you so much.
Thank you.
Thank you.
Thank you.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions, or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.